In this podcast, we'll be discussing rotator cuff tears and biceps tendon pathology, in particular, some pearls with regards to the epidemiology, history, and physical examination. With regards to rotator cuff tears, the prevalence is age dependent. Approximately 30% of those over the age of 60 will have a rotator cuff tear. In general, the prevalence increases with age. Some risk factors include males, smokers, involvement of the dominant arm, as mentioned, age, and then as well as a history of trauma. Yamamoto et al. Performed this epidemiologic study done in a Japanese village looking at 683 subjects or 1,366 shoulders. The mean age of their population was 58, and they found that overall 21% of patients had a rotator cuff tear, and prevalence increased in each successive generation, with 25% of patients in their 60s, 45% of patients in their 70s, and 50% of patients in their 80s with cuff tears. Furthermore, they correlated symptomatology with the presence of a tear. 36% of patients with symptoms had a cuff tear, meaning 64% of patients with symptoms did not have a tear, and then 17% of patients without symptoms also had cuff tears. Other findings in this study included older age, more males, dominant arm involvement, and history of trauma in the rotator cuff tear group. With regards to the long head of the biceps, in general, the function of the long head of the biceps is not well understood. There's been some biomechanical studies to suggest it may act as the anterior stabilizer, a posterior stabilizer, or even a head depressor. Some people, Dr. LeBlanc included, call it the appendix of the shoulder, and suggest it may be a vestigial structure. However, there's a high incidence of long head of the biceps pathology with symptomatic cuff tears. In one group, 45%, in another group, Murthy et al., 82% of patients. In terms of the etiology of biceps tendinopathy, it occurs as a continuum and may be due to multiple factors, including inflammatory, degenerative, overuse, and traumatic causes. In general, an inflamed and mobile tendon may undergo further mechanical irritation, resulting in early tendinosis, which consists of sort of a thickened and fibrotic sheath that's edematous and degenerated. With further inflammatory disease, the end result is end-stage tenosynovitis or tendinosis, which ultimately results in an immobile and scarred degenerative tendon that is prone to spontaneous rupture. The T2 MRI image demonstrated here demonstrates fluid and inflammation surrounding a biceps tendon, indicated by the white arrow. In terms of the biceps rotator cuff connection, the sheath of the biceps tendon is continuous with the synovial lining of the glenohumeral joint, and is therefore intimately related with the rotator cuff. The inflammatory process that involves one of these structures will likely involve the other. In terms of some history pearls, in general, the symptoms of biceps pathology, which includes tendinitis and tendinopathy, as well as instability, and rotator cuff disease, have significant overlap, as do many shoulder pathologies. For example, patients typically report generalized shoulder pain that is worse with overhead activities and worse at night. There may be a history of trauma. Pain with biceps pathology is commonly reported in the anterior medial aspect of the shoulder. Pain may radiate down the groove. Long head, the biceps tendon subluxation may occur as an acute event and is typically associated with a subscapularis tear. These patients may report a mechanical event with subsequent symptoms such as popping, clicking, or snapping. In terms of the physical examination, looking at biceps tendon pathology, we covered most of this in talk previously, so we won't belabor the points, but some pearls include the following. So on your inspection, looking for the presence of a Popeye sign, which is demonstrated in the image on the right, which is indicative of a long of the biceps tendon rupture. In terms of your palpation, point tenderness in the bicipital groove is one of the most common findings of biceps pathology. You may get medial biceps instability, which can be elucidated with abduction and external rotation, assessing for a painful click or tenderness to palpation. And in terms of some special tests, the Jurgensen and speed test. The Jurgensen test is pain with palpation with resisted supination with the elbow at 90 degrees of flexion. The speed test is pain in the groove with resisted forward flexion of the arm with the forearm supinated and the elbow extended, the humerus in 90 degrees of forward flexion. Both the speed and Jurgensen's are specific but not sensitive. They have a likelihood ratio that hovers around 2. The O'Brien active compression test for slap lesions is typically positive in biceps pathology as well. With regards to physical examination for the rotator cuff, again, there's a multitude of special tests assessing for each the rotator cuff tendons. I've identified here 4 tests with relatively favorable likelihood ratios. However, this is by no means comprehensive. Assess passive or active range of motion, which is important to assess for pseudoparalysis, which can be caused by a massive rotator cuff tear, is defined as active forward flexion to less than 90 degrees with full passive range of motion. Also ensures to test for a C-spine pathology and test for strength bilaterally. Proceed to perform special tests for rotator cuff tears. Some tests include the Job or empty can test for the supraspinatus, which is demonstrated there on the right, with a technique of abducting the arm to 90 degrees with the elevation in the scapular plane, internal rotation with the thumb to the floor, and pressing down on the arm while the patient attempts to maintain the position, testing for both weakness and pain. For infraspinatus or external rotators, looking for the ER leg sign, which is tested by passively flexing the elbow to 90 degrees and holding the wrist to rotate the shoulder to maximal external rotation, telling the patient to hold the arm in the externally rotated position, and if it starts to drift into internal rotation, the test is positive. Job has a positive likelihood ratio of 2.9, and the ear leg has a positive likelihood of 6.3. Moving on to the teres minor, so the hornblower sign. This is done by bringing the shoulder to 90 degrees of abduction and 90 degrees of external rotation, asking the patient to hold that position. This is positive if the arm falls into internal rotation or just pain. It may represent teres minor pathology and has a favorable positive likelihood ratio of 12. Then lastly, looking at the subscapularis, so one example being the belly press, which is performed by having the patient press on their abdomen with the palm of their hand, maintaining the shoulder in internal rotation. If the elbow drops back or doesn't remain in front of the trunk, then the test is positive. This test has a positive likelihood ratio of 12 to 20. Thank you.